Is there a big impact that you're seeing even after the Omicron wave?
Yeah, I'll just coming to it because you will just see that how the things evolved. When we were seeing the patients who were just bumping in the emergency, one after the other, and we didn't know how to treat. That was the irony. We didn't know how to diagnose them. That was another irony.
That was the
And,
the
and
first.
we didn't know how to even investigate them, how to make the severity of how to classify the severity of this COVID. I think we were totally in dilemma in the beginning. So natural history of this virus was not known to anybody in the world. It just came by surprise. Now, how did we diagnose? We took some time, but the diagnostic modalities of tests were divided into 4 components. The first was RT-PCR, which was very sensitive and specific. And nowadays, we do what is known as CBNet. CBNet is a quick RT-PCR. We get the report in just 45 minutes. And then, of course, rapid antigen test, but the sensitivity and the specificity is low. If it is positive, it's well and good. If it is negative, it does not rule out COVID. Then come the inflammatory markers, by which we could say that this patient is mild, moderate, severe, or critical, depending on the CRP levels, interleukin-6 levels, and ferritin levels, because they are the inflammatory markers. Then come the thrombotic marker, and that was D-dimer. And the severity was also depending on the level of the D-dimer, as mild, moderate, severe, and critical. This was a real development in the natural history of evaluating the virus severity in our clinical setup. The best modality of imaging was not known to us. Is it ECG, is it tropi, or is it echo, or is it HRCT? But ladies and gentlemen, I must tell you today, the best modality was CT scan, HRCT. Because the various segments of lungs which were affected, we could easily evaluate in great details, and we also established a scoring system there, what is known as CT score, less than 9, 9 to 14, 14 to 19, 20, and then people having 21 to 25, they were labeled as critical COVID. This also we learned. We are all in the learning curve. We were not aware of anything. And then came echo. Echo and vascular modality was of a tremendous help to understand the structural, functional, and the flow profile abnormality which are caused by the COVID virus. I think they were very, very important. And we also came to know that this virus definitely caused clotting. I just narrate one case. I think this was only 15 days of my experience. A chartered accountant called me, a 32-year-old, that he had a chest discomfort and a little feeling of giddiness. And I sent him to the hospital. His CT was done, he had a small, tiny infarct in the brain, what we call as a brain attack. We did his ECG and we found he had a heart attack together. And the cause was COVID. First case of my life who came with 2 attacks at the same time, COVID infected in a young guy with no comorbidity. That is what COVID is all about. And then the simple thing which we came to know is we should do SpO2, a very bedside marker by which you can see the oxygen saturation and classify the severity, mild, moderate, or severe. But if it is less than 90, we used to hospitalize the patient. We also can see the heart rate. If the heart rate is more than 120, it gives a red signal. If the respiratory rate is more than 30, red signal for hospitalization. So see the clinical marker. So we had clinical markers, we have inflammatory markers, we had thrombotic markers, and we had imaging markers. So we achieved perfection in the clinical management over a period of time. Then comes genetic sequencing. See the development, how it progressed. Genetic sequencing played a very, very important role to assess the various mutations because the virus were going very fast And I think Ashali just asked me as to what are these various mutations like alpha, beta, gamma, delta, and then Omicron. And again, Omicron is BA1, BA2, and so many variants are there now in the whole world. And I think these viruses mutation vary in the severity of virulence and transmissibility potential. When Delta virus came in the second wave, that was the most deleterious. It was like a horror. A lot of young people fell victim to Delta virus and passed away. And this virus has a very high mortality, irrespective of age, sex, comorbidities, or no comorbidity. So that was a very highly virulent virus, second wave. Third wave we have was Omicron virus. And we thought it's a very mild virus, but it is not mild. Even the Omicron virus is mild, low virulent, but the transmissibility is very high. And we had seen a lot of patients who were beyond 70 and 80, they also passed away because they were high morbidity and more thrombosis. So all the individuals who are beyond 70, 75, the mortality of Omicron infected is also relatively high. We should not underestimate it. That's a very important message. And the Omicron virus has a very high transmissibility. So that was a very, very marked potential of this virus, but definitely less virulent. 90% of patients were treated at home and they no residual effect.
हेल्थ, फिटनेस और पोषण पर पाए बेस्ट डॉक्टर्स की राय सिर्फ famhealth.in पर और हमारी YouTube पेज माय फैम हेल्थ पर सब्सक्राइब करना ना भूलें।